I'd like to welcome you to this edition of the PRS Journal Club podcast with your hosts, Dr. Sammy, Sinno, Amanda Silva, and Raj Sawh-Martinez. Enjoy.
Hello, and welcome to the August 2016 edition of the PRS Journal Club. My name is Raj Sawh-Martinez, and I'm joined by my fellow resident ambassadors, Amanda Silva and Sammy, Sinno. This month, we're honored to be joined by ASPS President-elect Dr. Debra Johnson. Dr. Johnson attended medical school and completed her plastic surgery residency at Stanford University. She's a general plastic surgeon in a group practice in Sacramento, California, and clinical faculty at UC Davis. Dr. Johnson has a long and distinguished career, not only as a master surgeon, but a staunch and dedicated advocate for our patients through her leadership of the California Society of Plastic Surgeons and nationally through the American Society of Plastic Surgeons. Dr. Johnson, thank you so much for taking time out of your, I'm sure, extremely hectic schedule to join us.
Oh, no, it's a pleasure. Thank you.
So today we'd like to start the discussion with a study by Michelle Roughton and her colleagues out of the University of North Carolina at Chapel Hill entitled Distance to a Plastic Surgeon and Type of Insurance Plan Are Independently Predictive of Post-Mastectomy Breast Reconstruction. In this study, the authors looked for predictive factors that were linked to patients being able to have breast reconstruction after mastectomy. The authors used the North Carolina Central Cancer Registry and combined this with claims data for Medicare, Medicaid, and private insurance between 2003 and 2006. They identified over 5,300 women who had received mastectomy and had at least 2 years of consecutive insurance. The authors used a multivariable logistic regression to model the odds of having reconstruction and adjusting for demographic and tumor characteristics. They found that about 20% of the population received reconstruction and that the distances of 10 to 20 or greater than 20 miles away from a plastic surgeon lowered the odds ratio of a patient having breast reconstruction by 22% and 27% respectively. This is compared to patients who lived within 10 miles of a plastic surgeon. This is independent of known disparities, including age, race, rural location, and lower income. The authors also found that patients with government-funded health care, Medicare or Medicaid, were also less likely to receive reconstruction. Minority women were found to have 50% lower odds ratio for receiving reconstruction compared to non-Hispanic whites, and known factors of age, advanced cancer stage, and receipt of radiation were also found to decrease the odds of having reconstruction. In an additional analysis, the authors also compared immediate to delayed reconstruction, and for women who received reconstruction, distance was not associated with a delayed versus an immediate reconstruction. However, the authors did note that rural location, chemotherapy, and radiation were predictive of delayed reconstruction. The authors note that women living in rural counties were 63% more likely to receive delayed reconstruction. As in all studies, there are some limitations to the data, and in particular here, this data comes from one state, and then the authors point out that North Carolina is the ninth largest state and socioeconomically diverse. However, there may be things that are not translatable to other areas. Distances were done in straight line measurements based on zip code. Driving distance may be, in fact, longer. And then the distance was not necessarily to the closest plastic surgeon overall, but the closest surgeon that's reimbursed by the patient's insurance. This may be an issue of limited number of surgeons providing breast reconstruction or issues with insurance reimbursement or coverage or a mixture of both of these. Also, the delayed group was based on claims data of greater than 4 months after mastectomy and may be a little bit arbitrary. Individual income levels were also not attained. And importantly, patient choice or decision-making is something that they really could not look in the study based on the database. Overall, there's a lot here. The study is very well executed and really sheds important light on a nationally important issue. ASPS was actually able to achieve significant milestones this past year with successful lobbying and passage of the Breast Cancer Patient Education Act, which appropriates funds geared towards patient education of the reconstructive options. I think this study is really an important addition to the literature that demonstrates that we really still do have a long way to go to optimize care for our breast cancer patients. And obviously, I have a lot to say about this topic and this study in particular, but I'd like to open up the discussion to our group. And Dr. Johnson, you've been obviously an integral leader on so many legislative battles, the California State Society, leading the Legislative Advocacy Committee, now President-elect of ASPS. I'm just really curious to hear sort of your thoughts on this study and its implications.
Yeah, I think this is a very interesting study, and I applaud Michelle Roughton for carrying this out. It's interesting in a couple of regards. You know, one of the issues that brought us to bring the Breast Cancer Patient Education Act forward was Amy Alderman's study that showed that women weren't being told of their reconstructive options, and particularly women in rural areas and of lower socioeconomic class. And so I think that this study, reiterates that by showing that women who live a distance from a plastic surgeon are less likely to have reconstruction, and Medicaid women are less likely to have reconstruction. So I think it shows us that although this was from 2003 to 2006 data, so hopefully we're a little better nowadays, but it does play up the fact that these women are still not being informed of their reconstructive options or not taking advantage of their reconstructive options. One of the things that I think is important is in a rural county where there may not be a plastic surgeon, a general surgeon has to kind of give up the patient if the patient chooses to have an immediate reconstruction. So there may be some, economic bias on the part of the general surgeon that they don't necessarily want the patient to seek immediate reconstruction because that way they lose the case. Also, patients may not want to do that much driving. They're hit with the diagnosis of breast cancer, and sometimes that's so overwhelming they can't think of driving a distance to be able to see a plastic surgeon and to have surgery perhaps at a distance. So there's a lot, both patient factors and physician factors that play into this. And I think it's really important that we as plastic surgeons kind of come up with some inventive ways to inform patients of their options. I thought it was cute that one of the things that University of North Carolina has started doing is teleconsultations where they offer the possibility of a patient to speak with a plastic surgeon at a distance via, I'm not sure how they're doing it. Probably UNC has a nice teleconferencing system, but even via Skype, a plastic surgeon can talk to a patient beforehand and to determine if that patient is a candidate and to inform them of what their options might be. And I think that that's a real interesting and novel approach to get information to women in more rural areas. Unfortunately, at the present moment, teleconsultation is not a reimbursable event. And so if you're doing that, it's kind of out of the goodness of your heart. There's certainly a lot of work going on trying to make that a reimbursable event. But right now, CMS and the major payers say unless you're face-to-face, you can't charge for a consultation. So, it's a changing environment. I think it does once again open our eyes to the fact that people in rural areas and of lower socioeconomic classes are at a disadvantage, and we need to do everything we can as plastic surgeons and kind of push government and the payers to help us along with coming up with novel ways to reach those patients.
Those are great comments and great thoughts, Dr. Johnson. One of the things in my mind, I see it sort of in two fronts. One, Amanda's interested in microsurgery, is going to be one of our fantastic breast microsurgeons, I'm sure, or reconstructive surgeons down the road. But are we training enough people around the country to do complex microsurgical reconstruction? And prior studies that we've looked at and discussed even in these podcasts have looked at reimbursement for these sort of bigger cases. Will this be something that will sort of die out and be only at specialty centers and maybe even make the problem worse if we don't do something ahead of time?
Yeah, it's hard to know. It is a little bit what the market will bear, and I certainly think that if patients are demanding of microsurgical reconstruction, certainly, we get fantastic results with free DIPs and muscle-sparing trams and that sort of thing that, it would be nice to be able to offer that to everyone. Unfortunately, in a lot of rural areas, the technological things you need for some of those procedures are not readily available, and, you have to train your nurses, et cetera. So it may still require a little more regional type treatment for those surgeries. But be that as it may, there may be things that, for instance, I don't do free breast reconstruction, but I send my patients to the Bay Area or to Stanford, and then I do all the post-op care. So the patients can have their surgery and then still be able to see a local surgeon. It could even be their general surgeon, but if there's good communication between the reconstructive microsurgeon and either a local plastic surgeon or the local general surgeon, those patients can still be cared for without having to schlep back and forth to the major medical center to have follow-up with the microsurgeon personally. So I think there's ways that we can make all this happen. We just have to be a little more collaborative and try to work out ways that we can get people reimbursed for their time, but make it a team effort.
Mm-hmm. Yeah, that's an interesting point that you bring up, Dr. Johnson, because it's unclear if patients aren't receiving reconstruction because they just completely aren't being referred, or if it is simply a distance thing and they don't want to travel that far. That can't be parsed out in this data. And so, like you mentioned, if it possibly is referrals and just having the support and not necessarily being down the street from a microsurgeon, it would be interesting to find out, down the road why, and then also to build this infrastructure, because if that's the problem, that's a little bit easier rather than saying we need to have microsurgeons within a 10-mile radius of every patient.
Sure. The thing that surprised me in this study, though, was that, that it was statistically significant if the distance was over 10 miles. Which I thought was kind of surprising because, a lot of people will drive more than 10 miles, to go see a movie. So, I found it surprising that was the break point. So, if you have to have a plastic surgeon within 10 miles, that would, with only 7,000 of us nationwide, that might be a little hard to cover the whole map. So,
I will say that I think it may even be longer than that in the sense that they talked about it being sort of zip code dependent, and it's sort of a straight line. So in my head, if there are hills, mountains, et cetera, that could be radically different.
A much longer drive.
The crow flies. Yeah. Right. So, but I agree totally, Dr. Johnson. I was like, wow, that 10 miles doesn't seem that bad. But there is also a greater than 20 mile group, and I don't know, at NYU, if Sammy's got to go more than 2 miles, he's not going. So, it's probably also very geographically dependent.
In New York, if it's more than 8 blocks, you're not going.
Right, exactly. Well, one thing I do want to say that I've gained an appreciation for as my training's gone on is the just tremendous information overload it is for patients that are faced with breast reconstructive options. I'll never forget the first time I was in a consult hearing and attending explain options to patients, and even as a resident with years of training, it can be just really hard for me to understand how patients can really grasp everything in the context of dealing with their cancer as well. One thing I know Dr. Song does, and a lot of other surgeons do, is have platforms where they have a lot of information that they can electronically send to patients. And I think, those initiatives, all the information that the ASPS is trying to put out for patients really will heighten patient education. And I think, ultimately, as we mentioned, physical distance really shouldn't be a barrier if it's within reason to the reconstruction option of choice. What do you recommend for patients preoperatively, Dr. Johnson, in seeking out breast reconstruction?
In terms of where to find information, or?
Yes, exactly.
Certainly. In our consultation, we give them a lot of information. California has a mandated kind of breast cancer brochure that includes reconstructive options in it that every patient gets. I send them to my own website, which has information regarding reconstructive options, certainly the ASPS website, and some of the other support group, Komen Foundation and American Cancer Society. We have a dedicated breast cancer center here in Sacramento, and many cities have a breast cancer center, and those are wonderful resources with breast navigators that are trained and can sit down with patients and kind of give them all the information. I try to unfortunately, when you get a cancer diagnosis, most patients are, initially panic-stricken and want to have their surgery tomorrow. And I try to convince patients that with breast cancer, it often is, it's a little more slow-growing kind of cancer, so you do have some time to try and think things through and to really think about your options and not put your health at risk, but give yourself time to determine what's the best path for you to take moving forward, whether it's immediate reconstruction or delaying reconstruction. And it, but it is overwhelming for some patients. Some patients say, oh, I can't even think about reconstruction at this point. I just want to get rid of the cancer. And, and we say, that's fine. Come back when you're healed. Let's sit down when we've got time to contemplate our options and do it in a more relaxed manner. But I do always encourage patients to consider immediate reconstruction, because I think the outcomes are more gratifying for both the surgeon and for the patient. They don't have to go through that period of missing a breast and the double recuperation, et cetera. So I think it is important to give the patient enough of your time to make them feel comfortable that having reconstruction at the time of the mastectomy is not going to put their health at risk. Taking the time to consider all their options is not dangerous, and to try and help them through making the best choice for themselves.
Great. That's well said.
You mentioned that mandated brochure through the state of California. Who edits that, and is it looked at every year or every 5 years, or how is that regulated? Do you know?
Yeah, it's run through the Department of Health Services, and it was actually, it's been in existence for probably 20 years. It was a legislative mandate, and my partner and I were actually wrote the breast reconstruction portion of it because we're local. So, and it does it gets readdressed. I think usually about every 5 years it gets readdressed to see, if there's updates, et cetera. So, they send me the PDF periodically, and we update it and send it back. So it's been kind of a nice way for patient, because it also has references for the patient to seek other sources of information, other websites and groups that they can contact. So it's kind of nice for the patient because it gives them, kind of a synopsis of treatment options and also more information.
Yeah, that's great.
Awesome discussion, everyone. Thank you so much. And I think one of the last things here to say that it's always surprising to me when you see these numbers. I think at all of our centers, and I'm sure with you, Dr. Johnson, so we see so many patients who come in for breast reconstruction, but when you look at these studies, we realize that only 20% of patients actually get reconstruction ultimately. It just seems extraordinarily low. So we do hope that these efforts and your efforts, Dr. Johnson, on the ASPS is really going to help to increase that significantly over the years to come. And then just probably we can make a small plug for any residents or junior faculty, whoever looking to get involved, Dr. Johnson, recommendations on how they can get involved with legislation either locally or nationally?
Sure. Well, I think although this is 20%, it is one state, and it is about 10-year-old data. So it has been shown more recently that more women are choosing to have reconstruction. I think we're up over 40% now. So that's a good sign. But there's still a ways to go, and certainly the Breast Cancer Patient Education Act, Dr. Song met with members of Congress and did a briefing, and so we are working with HHS to try and beef up the patient education regarding breast reconstruction as part of that act, and ASPS is actively involved in that. So that'll be a new resource for our patients. I think that anyone who's interested in legislative advocacy, I strongly encourage you to get involved by participating in our legislative fly-ins. You can subscribe to the ASPS Focus, which is our legislative emails that go out once a week. You can volunteer for the government, the Legislative Advocacy Committee, which is a great way to get involved. And also at your local level, either your local medical society, your state and regional medical society, because a lot of the legislative issues are local, because our state legislators tend to, respond to headlines, and they affect us more than the feds. The federal people don't usually get involved in in mandating health plans to provide coverage, et cetera, but the states do that more often. So getting involved at your state level is really important. And so your state society would have a legislative committee and volunteer for that. It's a great way to get involved in organized plastic surgery and a way to help your fellow members to avoid onerous or ridiculous legislation by convincing the legislators that what they're planning on doing may not make medical sense, even though they're responding to a headline or to a patient complaint. It may not be appropriate medical care. So it's important to have physicians at the table to educate the legislators, and the more plastic surgeons we have involved in that, the better it is for our patients.
Terrific. Well, thank you so much, everyone. Thanks so much, Dr. Johnson. And we'll leave it there. We'll pick it up soon. Thanks again.
Okay, thank you.
Yeah, thank you.